Good morning, everyone. I'm Dr. Asim Hussein, and I'm pleased to welcome you today. We'll be discussing Abdominal Compartment Syndrome, or ACS. This is the first slide, so I just want to give you a quick overview. Today, we'll cover what ACS is, why it's important, how it's diagnosed, and the treatment options available. I look forward to sharing this important topic with you. Let's get started. All right, let's take a closer look at this case. We have a 56-year-old man with severe acute pancreatitis who's receiving large-volume fluid resuscitation. Now, as you know, fluid resuscitation is crucial in pancreatitis to maintain perfusion, but it can sometimes lead to complications. In this scenario, he's developing worsening oliguria, which indicates his kidneys aren't producing enough urine, and that's a red flag for potential kidney injury or other systemic issues. Additionally, we're seeing rising ventilator pressures, suggesting his lungs are becoming less compliant, possibly due to increased pressure in the chest or abdomen. He also has hypotension, meaning his blood pressure is dropping, which can be due to multiple factors like hypovolemia or increased intra-abdominal pressure. Speaking of intra-abdominal pressure, the bladder pressure measured at 28 mmHg is a key detail here. Normal bladder pressure is usually below 12 mmHg, and pressures above 20 mmHg suggest intra-abdominal hypertension. When pressures go beyond 25 mmHg, especially with organ dysfunction, it points toward abdominal compartment syndrome. So, connecting all these signs, worsening kidney function, increased ventilator pressures, hypotension, and a high bladder pressure, this picture strongly suggests we're dealing with abdominal compartment syndrome. This condition occurs when increased intra-abdominal pressure compromises blood flow and organ function, which is a serious complication in critically ill patients, especially after large-volume resuscitation. Understanding this helps us recognize the importance of monitoring intra-abdominal pressure in such patients, and highlights the need for timely intervention to prevent irreversible organ damage. The correct answer here is C. Now, let's clarify what ACS actually is. ACS stands for Abdominal Compartment Syndrome, and it's characterized by a sustained increase in intra-abdominal pressure, specifically equal to or greater than 20 millimeters of mercury. But that's not all. It's also associated with new organ dysfunction. So, it's not just about the pressure itself, but the fact that this elevated pressure starts to impair the function of organs within the abdomen or even systemically. Recognizing this threshold is crucial because it helps us identify when intra-abdominal pressure becomes a serious problem that needs intervention. This concept ties into our overall discussion about managing critically ill patients and the importance of monitoring intra-abdominal pressures carefully to prevent organ failure. All right, let's focus on the question here. When we're dealing with an ICU patient who is at risk of abdominal compartment syndrome, or ACS, it's crucial to accurately measure the intra-abdominal pressure. Now, the question asks, what is the recommended method to do this? Looking at the options A and B, abdominal ultrasound and CT abdomen, are imaging techniques, but they don't provide a direct measurement of pressure. Instead, they're more useful for visual assessment of the abdominal organs and structures. Option C, central venous pressure, measures pressure in the central veins, which is related to cardiac preload, but it's not a direct measure of intra-abdominal pressure. Option E, gastric tonometry, measures gastric mucosal CO2 levels to assess mucosal perfusion, but again, it doesn't give us the intra-abdominal pressure directly. That leaves us with option D, transbladder or intravesical pressure measurement. This method involves instilling a small amount of saline into the bladder and measuring the pressure through a catheter. It's widely regarded as the gold standard for assessing intra-abdominal pressure because it's minimally invasive, reliable, and directly reflects the pressure within the abdominal cavity. So, in summary, when confirming intra-abdominal pressure in a patient at risk of ACS, the recommended method is the transbladder or intravesical pressure measurement. This technique gives us the most accurate and practical assessment, which is vital for guiding management decisions. Remember, accurate measurement of intra-abdominal pressure is essential in the overall theme of this presentation: early detection and intervention to prevent the serious consequences of abdominal compartment syndrome. Let's take a look at this question. The correct answer is D now. The explanation here is quite straightforward but very important. Bladder pressure measurement via a Foley catheter is considered the standard, indirect method for measuring intra-abdominal pressure. This technique is widely used because it's reliable and relatively simple to perform. Essentially, by inserting a Foley catheter into the bladder, we can indirectly assess what's happening inside the abdominal cavity. This method helps us monitor patients at risk for increased intra-abdominal pressure, which can be critical in managing their overall condition. So, understanding this technique and its significance is key in clinical practice, especially when we're dealing with critically ill patients or those with potential intra-abdominal hypertension. All right, let's look at this question. We have an ICU patient with a measured intra-abdominal pressure of 16 mmHg, and importantly, there's no organ dysfunction observed. Now, the key here is understanding how we classify intra-abdominal pressure levels. Normal intra-abdominal pressure, or IAP, is generally considered to be less than 12 mmHg. When it starts to rise, we classify it into grades. Grade I is from 12 to 15 mmHg, grade II from 16 to 20 mmHg, and so on. Since our patient's pressure is exactly 16 mmHg, that puts it right at the beginning of grade II intra-abdominal hypertension. It's also crucial to note that the classification depends not just on the pressure reading, but also on whether organ dysfunction is present. Because this patient has no organ dysfunction, this measurement alone places him in the grade II category. So, to answer this question, we would select grade II intra-abdominal hypertension, which corresponds to option C. This classification helps us understand the severity and guides our management decisions accordingly. Let's take a closer look at the correct answer, which is C. When we're evaluating intracranial hypertension, or IAH, we look at the intracranial pressure, or IAP. An IAP of 12 mmHg or higher is considered indicative of IAH. We further classify the severity into grades. Grade I ranges from 12 to 15 mmHg, which is mild. Grade II spans from 16 to 20 mmHg, indicating a more moderate level. Now, when we move to ACS, or acute cerebrovascular syndrome, the threshold is generally an IAP of 20 mmHg or higher, but importantly, this is accompanied by signs of organ failure. This highlights how critical it is to not only measure the pressure, but also assess the patient's overall condition. Connecting this back to our overall theme, understanding these pressure thresholds helps us determine the severity of intracranial hypertension and guides our clinical decision-making. Recognizing these grades and their implications can be vital in managing patients effectively and preventing further complications. Let's look at this question about managing early abdominal compartment syndrome, or ACS. When we see a ventilated patient with rising bladder pressures and decreasing urine output, it suggests that intra-abdominal pressure is increasing and starting to affect organ function. This is a critical sign that we need to act promptly. So the key here is choosing the most appropriate initial management. The options range from immediate surgical intervention to more conservative measures. Immediate laparotomy, for example, might be necessary if the situation is severe, but in early stages, it's often better to start with less invasive approaches. This is where optimizing medical measures to reduce intra-abdominal pressure becomes essential. By adjusting things like patient positioning, ensuring adequate sedation, and reducing fluid overload, we can often lower the intra-abdominal pressure and prevent progression. Highlighting the most important concept, it's crucial to recognize early signs and focus on medical management first, rather than rushing straight to surgery. This approach aligns with the overall goal of preventing organ failure and improving patient outcomes. In summary, for a patient suspected of early ACS, the best initial step is to optimize medical measures to reduce intra-abdominal pressure, rather than immediately resorting to surgery or other more aggressive interventions. The correct answer here is C now. Let's talk through the initial management steps. First, sedation and, if necessary, neuromuscular blockade are important to help reduce abdominal wall tension and patient discomfort. Next, nasogastric or rectal decompression can be very helpful in relieving intra-abdominal pressure and preventing further complications. A restrictive fluid strategy combined with diuresis is also key to avoid fluid overload, which can worsen the situation. And finally, if there are intra-abdominal collections, such as abscesses or fluid accumulations, draining them is essential for effective management. These steps are all part of a comprehensive approach to stabilize the patient and prevent progression of the condition. Now, let's look at this important clinical scenario. Despite our best efforts with conservative management, the patient's intra-abdominal pressure remains elevated at 26 mmHg, and we're seeing worsening renal and respiratory failure. This indicates that the condition has become quite severe and is not responding to initial treatments. The question here is, what is the definitive management in this situation? We have several options to consider. Continuing conservative management might not be sufficient given the current deterioration. Increasing PEEP could help with respiratory issues, but it doesn't address the high intra-abdominal pressure directly. Using vasopressors alone won't resolve the abdominal compartment issue and might even worsen organ perfusion. Paracentesis only removes fluid temporarily and might not be enough in this context. That leaves us with decompressive laparotomy, which is a surgical intervention to relieve the pressure directly. When intra-abdominal pressure is causing organ failure and not responding to medical therapy, decompressive laparotomy is often the definitive step to prevent further deterioration. So, in this scenario, the best choice is option D, decompressive laparotomy. It's crucial to recognize when medical management is no longer sufficient and to act decisively to protect the patient's vital organs. The correct answer here is D. Surgical decompression is really indicated in cases of refractory acute compartment syndrome, especially when there's ongoing organ failure. Essentially, if conservative measures fail and the patient's organs are still compromised, surgical intervention becomes necessary. It's a critical step to prevent irreversible damage. This ties into our overall theme of timely recognition and appropriate management of compartment syndrome. Remember, prompt surgical decompression can be life-saving and limb-saving in these severe cases. Let's wrap up with a quick summary of abdominal compartment syndrome, or ACS. This condition is essentially a dangerous increase in pressure within the abdominal cavity that can have serious consequences. It's important to recognize that ACS often develops from underlying issues like trauma, bleeding, or swelling, which can cause the pressure to rise rapidly. The key points to remember are that early detection is crucial because the elevated pressure can impair blood flow to vital organs, leading to organ failure if left untreated. Monitoring intra-abdominal pressure is a vital part of managing at-risk patients. Treatment typically involves relieving the pressure, sometimes through surgical intervention, to prevent further organ damage. Overall, understanding ACS is essential because it ties into our broader discussion of trauma management and critical care, highlighting how prompt diagnosis and intervention can truly save lives. Let's take a closer look at the definitions related to abdominal compartment syndrome. First, IAH, or intra-abdominal hypertension, is typically defined as an intra-abdominal pressure, or IAP, of 12 millimeters of mercury or higher. This is important because it helps us identify when the pressure inside the abdomen starts to become elevated and potentially problematic. Moving on to ACS, or abdominal compartment syndrome, the threshold is a bit higher. It is characterized by an IAP of 20 millimeters of mercury or more, but crucially, it's not just the pressure alone that defines it. The increased pressure must be accompanied by new or worsening organ dysfunction. Understanding these definitions is key because they help us distinguish between less severe intra-abdominal hypertension and the more serious, organ-threatening condition of ACS. Recognizing these thresholds allows us to intervene timely to prevent further complications. This slide sets the foundation for understanding how elevated intra-abdominal pressures can impact organ function and the importance of early diagnosis and management in the overall context of patient care. Let's take a closer look at some common causes of ICU admissions related to abdominal issues. One of the key reasons is severe pancreatitis, which can cause significant inflammation and systemic effects that require intensive management. Another major factor is massive fluid resuscitation, often needed to stabilize patients with shock or severe infections, but it can also lead to complications like abdominal compartment syndrome. Trauma or intra-abdominal bleeding is also a critical cause, especially in cases of blunt or penetrating injuries. Sepsis, which is a severe infection spreading through the bloodstream, frequently results in organ dysfunction and demands close attention. Ascites, the accumulation of fluid in the abdominal cavity, can signal underlying conditions like liver cirrhosis or cancer and may contribute to increased intra-abdominal pressure. Lastly, abdominal compartment syndrome, or ACS, is a serious condition where increased pressure within the abdomen impairs blood flow and organ function. Recognizing these causes is vital because they often overlap and can escalate quickly if not managed promptly. Connecting this to our overall theme, understanding these common ICU causes helps us prioritize early intervention and targeted therapies to improve patient outcomes. Let's talk about the clinical consequences that can arise from these physiological changes. When renal perfusion decreases, it can lead to oliguria or even acute kidney injury, which is a serious concern. Increased airway pressures can result in hypoxia because it becomes harder to ventilate properly. A drop in venous return can cause hypotension, reducing the amount of blood returning to the heart and affecting overall circulation. Gut ischemia is another critical issue, where inadequate blood flow can damage the intestines. Finally, we have abdominal compartment syndrome, or ACS, which occurs when increased pressure within the abdomen compromises organ function. These consequences highlight how interconnected our organ systems are and why early recognition and management are so crucial to prevent further complications. Let's move on to diagnosis, which is a crucial step in managing abdominal compartment syndrome. One of the most reliable methods is bladder pressure measurement, which is considered the gold standard. This technique involves measuring the pressure inside the bladder to estimate the intra-abdominal pressure. Understanding intra-abdominal pressure is key because elevated pressure can impair organ function, so accurate measurement helps guide appropriate intervention. Now, when we talk about abdominal compartment syndrome, or ACS, we're referring to a condition where increased intra-abdominal pressure causes significant organ dysfunction. Detecting ACS early through reliable measurement methods like bladder pressure monitoring allows us to make timely decisions and potentially prevent serious complications. So, in summary, accurate diagnosis through bladder pressure measurement is essential in identifying and managing ACS effectively, fitting into the overall theme of early recognition and intervention to improve patient outcomes. Let's now discuss the management approach, which is often stepwise. First, medical optimization plays a crucial role. This includes sedation to reduce patient agitation, decompression to relieve pressure, and ensuring adequate fluid management. These initial steps are vital to stabilize the patient and prevent further complications. Next, we focus on draining collections or ascites. Removing these fluids can significantly reduce intra-abdominal pressure and improve organ function. If the patient doesn't respond to these measures, then decompressive laparotomy may be necessary. This is a more invasive step, but can be life-saving when other interventions fail. Finally, we have to be vigilant about abdominal compartment syndrome, or ACS. This is a severe complication where increased pressure within the abdomen impairs blood flow and organ function. Recognizing and managing ACS promptly is key to improving outcomes. So, overall, managing intra-abdominal hypertension involves a stepwise approach, starting with medical measures, progressing to drainage, and then surgical intervention if needed, always keeping ACS in mind as a potential critical development. Let's go over some key pearls for managing patients with abdominal compartment syndrome. First, it's crucial to always measure bladder pressure if ACS is suspected. This helps us accurately assess the intra-abdominal pressure and determine if it's contributing to the patient's clinical deterioration. Next, keep an eye out for rising ventilator pressures combined with oliguria. These can be red flags indicating increased intra-abdominal pressure, impacting respiratory function and kidney perfusion. Recognizing these early allows us to intervene promptly. It's also important to remember that over-resuscitation can actually worsen ACS. Giving too much fluid can increase intra-abdominal pressure, so we need to be cautious and tailor fluid management carefully. When medical therapy isn't enough to control the situation, surgery can be a lifesaver. Procedures like decompressive laparotomy can significantly reduce intra-abdominal pressure and prevent further organ damage. Overall, understanding these principles helps us better manage ACS and improve patient outcomes by intervening at the right time with the appropriate approach. Thank you so much for being here today. I truly appreciate your time and attention. I hope the presentation has given you valuable insights and practical ideas to take away. Remember, the key points we've discussed, whether it's the importance of innovation, collaboration, or continuous learning, are all about driving growth and success. As we wrap up, I want to emphasize that the journey doesn't end here. It's about applying these concepts and making a positive impact. Once again, thank you for your engagement and interest. I look forward to seeing how you implement these ideas moving forward.